all the participants who are participating from across the country. And also I take this opportunity as a pleasure to introduce today's webinar speaker, Dr. Vijayakumar. The topic is current concept in diagnosis and management of acute abdomen and ileus in cattle. It is relatively a rare subject, though it happens practically in the field. Many such cases happens, but it is not much talked about subject. But though we do not have any direct product to link with this particular condition, only on pure scientific merit, and Dr. Vijayakumar has done many such research on this particular subject, we have chosen this topic. So that is the reason of taking this topic. And regarding Dr. Vijayakumar, he has done a lot of research on this case study and research on this particular subject. And if I have to explain about Dr. Vijayakumar's introduction, Dr. Vijayakumar academically is a MUSc veterinary in clinical medicine, and he has done his PhD in internal medicine. And he was working in Namakkal Veterinary College, and just now he has been transferred to Madras Veterinary College. He is going to take charge with effect from tomorrow. And Dr. Vijayakumar has presented so many papers, published so many papers in the national journal as well as in international journal. That is 149 papers he has submitted so far. And he has an experience of total 20 years, and he has guided 5 PhD students, 5 MSc students, and many PG diploma students in their career to pass their subject. And he has received various awards like Bruno Memorial Award in 1994 as a BVSc student when he passed out. And he has received many awards from ISVM panel, many such awards for his oral presentations in different years, and which was conducted in different places like Namakkal Veterinary College, some in Maharashtra, some in Punjab, like that. Many such award he has got it. And in Tanuvas, Best Clinician Award was given to Dr. Vijayakumar in 2012. And his interest is critical care medicine. Therefore, he has been recently taking charge, or from tomorrow onwards, he is taking charge in Madras Veterinary College. And he has got merit scholarship in 1994-96 for his MUSc during that study. So I take this great pleasure, and it's a big opportunity for all of us to have such a knowledgeable academician to conduct this today's webinar. Therefore, once again, I welcome you. Please participate thoroughly. And if you have any questions in between, please send through chat. My colleagues will be noting down those questions. And then once the Dr. Vijayakumar's presentation is over, after that it can be answered one by one. If any extra questions are there, it can be answered separately by mail later. Thank you very much. Once again, welcome Dr. Vijayakumar. Over to Dr. Vijayakumar. Sir, please take over.
Thank you, sir. Thank you so much. At the outset, I thank Alembic with great respect to Karnanidhi sir and his team for giving opportunity for presenting a webinar on this topic. I congratulate and then thank the veterinarians all over India and the academicians from different colleges for attending this webinar. At the outset, I would like to thank my teachers. Because of them only I am here to present the topic. So going on to this, the topic given is current concepts in diagnosis and management of acute abdomen and ileus in cattle. That is the topic. Let us see how we are going to see the schedule. So we will discuss about acute abdomen, what are the various causes, how to diagnose these conditions, and they recommend the particular therapy in appropriate places. To discuss all these acute abdomen, finally to come to ileus, that is the purpose of the webinar, how to identify this ileus and recommends its medical management. Once you are able to distinguish the various causes of acute abdomen, ultimately we end up in ileus, and then the treatment becomes easy once you know the differential causes of acute abdomen. Coming on to the definition, this acute abdomen is always very serious, and it is presented in acute clinical sign. And when we are not treating it or attending to it, it goes to a life-threatening condition, and we may lose the valuable cow. So most of the conditions, it is very acute, and it is very challenging for the veterinarians because we don't have many gadgets and limited availability, limited parameters, especially supporting lab. And moreover, the owners are very frustrated. They are very nervous because it is costly animal, 70,000 or 80,000 animal, and moreover, it is pregnant or it is a high lactating animal. So they put on a pressure. So under these situations, what happens? The extensive pressure from the owner. Sometimes the animal will be with open mouth breathing, or sometimes falls down. All these situations restricts the veterinarian in getting the data. Sometimes he forgets because he has to attend to the animal to take care of his situation so that the animal is not lost. In that way, during the process, the veterinarian is not able to collect the history, which may be a catchy clue like colic in some cases, or maybe the change in the diet in some of the etiological causes. So in addition to taking the parameters, veterinarian has to attend to the animal, otherwise the animal may be lost. So veterinarian is given a responsibility to get the data, formulate the differential diagnosis, and he has to see how he is going to eliminate one by one, and then how to follow the rationale for the diagnostic plan, institute the immediate emergency treatment as well as the therapeutic plan in an orderly manner so that ultimately the animal is safe. So that is the idea about this the seminar. If you are able to get this catchy clue, that is the success of the webinar. Now, what are the causes of the acute abdomen? And many of the peoples and the successful practitioners already know the various causes. I am going to just list out and then very fastly going to tell its clinical signs and the management, ultimately to end up to identify the ileus. What are the causes? The causes is traumatic reticulitis or reticuloperitonitis. Pre-gas bloat may be a choke or caused by hypocalcemia or acidosis, or frothy bloat, or DH, or displacement of abomasum. It can be an intestinal obstruction, which is very important to identify the catchy clues so that we can refer to a surgeon as early as possible, or mesenteric volvulus cecal dilatation. I have put the ruminal acidosis at the end so that if there is more time, we can discuss more on the acidosis. And needless to say, a veterinarian has to rule out the various obstetric or gynecological conditions. To remember that, I have put simply as a hydrops, because hydrops also accounts for a very severely distended abdomen and then mimics the acute abdomen. So needless to say, you please look into the dystocia or the uterine rupture and those things caused by the reproductive tract. We are concentrating on the medico-surgical causes, which always causes a confusion or emergencies in the field. So having identified these things, we will be able to easily separate what is a paralytic ileus, and the success becomes more profit when you are going to attend to ileus. So going on to disease-wise, step-wise, traumatic reticulitis or reticuloperitonitis. So early stage, you may have fever for 1 or 2 days, and it may subsequently go down, and then tachycardia. If the animal is, there is a severe clinical sign, there may be arched back, stiff gait. So what is this deep pain response, you have to use a pain percussion hammer, not your flexor. Use your pain percussion hammer in the xiphoid. And severe, just blow, it will have a pain in the form of a grunt. If you do not have it, you can use your knee or a closed fist. Just thump on it, the animal will evince a grunt. Hypomotility of rumen may be evinced, and of course, most of the acute cases, there may be anorexia, and then drop in milk yield, and rectal examination, there is a scanty done. Maybe this will be present for 3 to 5 days and then may go on better. That means it may go for a adhesion formation and then become improved, or later on, if there is a disturbance, it can go for a chronic peritonitis. So you don't get a catchy clue unless there may be inflammatory change. One of the important parameter for an academician or a field vet is the abdominocentesis, because you give a clue whether there is a peritonitis involvement or not. So then how to do this paracentesis? Side 8 to 10 centimeter from the xiphoid, 8 to 10 centimeter lateral to the midline. So normally when I put a needle, you don't get this type of free flow of fluid. You'll normally get 2 ml, and then the quantity and the rapidity with which it flows, that is only is going to be more important. And then take this fluid for analysis of protein and then specific gravity and get the cells identified. Centrifuge this fluid, take the sediment, make a smear, and identify the cells, which gives a clue. More important is the protein as well as the specific gravity. So don't forget this side, 8 to 10 centimeter caudal from xiphoid and 8 to 10 centimeter lateral to the midline. So this is called as the cranial paracentesis abdominis site. We will see the caudal. Since this is related to reticulum, so we have seen this first, we'll see this subsequent. Then going for, if you have an abdominal ultrasonography, it is a very good clue because it helps us to identify the reduced reticular contraction, accumulation of fluid around reticulum, and the abscess. Now this picture very clearly shows this is your reticulum, this is the rumen, this is the H indicates the adhesions. And you will see another one case, this is the reticulum, you can see the abscess, and then a star speckled appearance or a fluid which indicates the abscess. So you can easily delineate whether it is a fluid or an abscess or an adhesion. That advantage is there whenever you have a ultrasonography. So now you can see this adhesion, extensive cob-web-like appearance, which forms the adhesion. Not only the adhesion, it prevents the reticulum from motility, and that is the reason why there is no onward transmission or the propulsion of the ingesta. If you have got additional radiograph, you've got a free fluid or a gas packets. Sometimes you can see the metallic foreign body also. And if you have a facilities, you can go for laparotomy or rheumatology to identify the foreign body or the needle. Let us see, this is a beautiful picture which indicates the needle, and this is the reticulum. The edge indicates the heart. A small needle over here. So the X-ray is also helpful in identifying the foreign body. Maybe if it is cost-wise prohibitive, ultrasound is good. One of the important point in prevention is the application of reticular magnet. The gun. You load this magnet in this and then introduce to the mouth. It can be easily applied. And you can see after application, this is the reticular magnet, and all your foreign bodies come on, stick onto it, and thereby it do not penetrate the reticulum or form the reticuloperitonitis or reticulopericarditis. So the prevention best is the administration of magnet. Once you see a cattle with an abscess or reticular abscess or an adhesion, so your medical treatment alone do not help. So you have to go for a surgical thing, or better maybe a contamination of the animal. Now let us see where the exploratory what is called as Pericardiocentesis caudal point will be helpful to identify the peritonitis. First, you have seen the cranial point to localize because it is very close to your reticulum, and you can see the caudal point. This is the ultrasonographic picture which indicates the cobweb appearance. These are the extensive fibrin deposits which indicates fairly was cased or more extensive adhesion. This is a caudal site. Okay, you can see the hind limb here, udder, in front of the udder. This is the point of udder, front of the udder. You introduce the needle. Here there is a fold of skin. Someone has to hold the fold of skin and pull it dorsally and introduce the needle towards the head. So the free flow of fluid indicates there is a peritonitis. This is a good site for, that is a caudal site. If you get fluid both in a cranial as well as a caudal site, that indicates it is a diffuse peritonitis. Now coming on to the next important acute abdomen is your free gas bloat. Then there is an history, there is access to the vegetables or fruits, and in maybe a chronic cases like in vagal digestion, also you may get the clinical signs, maybe abdominal distension or dyspnea, tachycardia or tachypnea, depending upon how far it is going to be there, and bruxism. Most important is the palpable swelling in the neck when it is near the cervical. Once it goes to thoracic, you may not be able to appreciate. And important is tyloria or dialism, excessive production, and left side abdominal distension. This beautiful picture here indicates the swelling over here, and here you can easily palpate the foreign body also. If it is in the cervical, I think you can put on a gag after sedation and then you can retrieve it. This is the dialism. The dialism with a severe left paralumbar fossa distension indicates that the case is very severe. Please attend to it very immediately. If you do not have the time, then you can also go for a trocarization of the left paralumbar fossa. Now, if the facilities is available, then you can go for endoscopic evaluation. Now you can see this is the beetroot and this is citrus fruit in the esophagus causing the choke. To assess the extent of damage or probably identify what is the foreign body. And then you can put on a gag, a Gunther's gag or whatever gag, drink water's gag, and then you can remove the foreign. One such is what you have removed is a beetroot. And then the important point, if there is a severe distension, you go for a trocar, Roman trocarization, and then take care that you have to put a nick with using a PP blade before putting on a trocar. So if you are not putting a nick, so how much pressure you exert, you may not be able to put the trocar and canal. So this is another way of diagnostic way is passing on the stomach tube. There will be a difficulty, you may not be able to successfully pass into the stomach. If it is an extra, the internal, the esophagus, if it is extra-abdominal, you will have a little bit resistance. However, you'll be able to pass the stomach tube into the stomach. And if it is in the cervix, past the cervical area and gone into the thoracic esophagus, then you have to go with a rheumatectomy or esophagus. Then there can be also a bloat due to hypocalcemia. It mostly occurs in the peripartum period. Animal is already weak and recommend. Other signs also will be there, cold extremities. Important point is the constipation, and you have got a slow pupillary light reflex. Okay, so what you have to do is serum biochemistry is supported by low calcium. So if there is a severe distension, go for trocar. Easy is to administer calcium, and then there is a bloat. The bloat gets relieved. So or you can also relieve it by orogastric. So more important can also occur in the peripartum period because of hypocalcemia. So it can be relieved by administration of calcium. Coming on to the frothy bloat, so you can already know this is which causes access to the legume, and then sometimes because high concentrated diet. So this is the one such case which indicates a frothy bloat, and the signs are the clinical signs is similar to your choke, but what happens is it is a stable froth. In case of a free gas bloat, pass on a tube, they gets relieved, or once you remove the foreign body, the gaseous distension gets relieved, or the left paralumbar fossa or abdominal distension gets relieved. But here, because of the stable froth, it don't get relieved, and the important is to reduce the surface tension. Use fluoxetine or mineral oil, so preferably by orogastric tube to avoid aspiration pneumonia. Now, if there is a recurrent bloat, so maybe because of the lesion, and it can be because of the amphistomes. So in the cardia, so which prevents the movement, the functioning of the cardia or the erectation reflex. And the foreign body syndrome, don't forget to rule out the DH and the vagal indigestion. Coming on to the DH, so the recurrent bloat is one of the important clinical sign, and so in case you have facilities, you can see the foreign body as well as the hernia over there, diaphragmatic hernia. The contrast X-ray will also help to identify the diaphragmatic hernia, and the diaphragmatic border which separates the chest and the thoracic cavity and the abdominal cavity may not be appreciable. Then important point is, if you have an ultrasound, it will be easy to identify a catchy clue for the diaphragmatic hernia. Please note H is the heart and R is the reticulum. Now in the next subsequent videos, you'll be able to see the close association of reticulum in movement with the heart. Please note this is the heart and this is the reticulum, which you will be able to see in the subsequent video. So this is your reticulum, this is the heart, and this is your valve. This is the left ventricle and this is the right ventricle. Kindly focus in this area where you will be able to identify the diaphragmatic hernia. Okay, now this is the heart with the valve moving. This is the reticulum. Okay, so the reticulum moves in association with the heart, because the reticular motility is not so fast. So it is because in association with the heart, you get a motility increase. The same thing can also be appreciated in the next video. So the same video has been put so for the appreciation of the participant. Now in this is a different animal. So this is a reticulum, and you will be able to see the heart movement. The probe is toward this side. That's why you are able to see the valve here. This is the heart, and this is the reticulum moving in unison with the heart. So that facilitates your identification of the diaphragmatic hernia. Now suppose you don't have facilities of X-ray or maybe ultrasound in that particular field. Now how to diagnose the diaphragmatic hernia is to do the thoraco-reticulocentesis. What is the parameter? You do it on the right side of the thorax. Auscultate the area where you get the peristaltic sound in the thorax. In that area, you put the lip tack test, aspirate the content, and see for the pH as well as the protozoa. You don't have any facilities to have a protozoa as well as the pH of 7 in the thorax. Okay, so it should be, unless it is a reticulum which herniated in the thorax, you don't have a protozoa as well as the pH of reticulorumen in the thorax. That is a beautiful technique, you can do it. So this is the area. Now we can see this is the forelimb. So secured, and then you can introduce the needle, aspirate the content, and then take the content, see for the pH. Roughly it gives about the 6 to 7 the pH, and put on a microscope to see for the protozoa. So that is one technique where you can identify the diaphragmatic hernia in the field condition. The next is simultaneous auscultation of right cardiac area with the palpation of left paralumbar fossa for diagnosis of diaphragmatic hernia in cat. So what is that? So you would have heard about Williams method of auscultation. What is the Williams method of auscultation? Keep the stethoscope on left hand on the 7th to 8th intercostal space for seeing the reticulum, and the left paralumbar fossa you are keeping the right hand. This is the Williams method of auscultation. So just understand this. Now we are going for this method, what is called as G.VIJAYAKUMAR auscultation technique. So in what cases it will be useful? It will be useful for a recurrent bloat and or recent calling. Okay, and there is abdominal distension, and you are unable to do the intubation. Maybe after repeated intubation, you will be successful. Then suspended rumination or reduced defecation. So this may be some of the criteria. In this case, now stand on right side of the animal, and then you can have the stethoscope on your right hand. Place the stethoscope on the right thoracic area, that is the cardiac area, 3rd to 6th rib. Then palpation is by your left hand. Keep it on the left paralumbar fossa, crossing the dorsum. Stand on right side, right hand on the right cardiac area. left hand on the left paralumbar fossa and start auscultating. Now this is a video which helps you to show. Stand on right side and you're keeping the hand here. The hand is crossing the dorsum of the animal, and then the right hand is kept in the right cardiac area. Okay, this is the technique, what you call as GV's simultaneous auscultation of right cardiac area and palpation left paralumbar fossa. So what is the result? The result is you'll be able to see the fixing sound or what is called as a peristaltic sound in DH. So otherwise, in the case of normal case in the animal which do not have diaphragmatic hernia, you will be able to hear the normal heart. Okay, so this is again helpful in the field condition as well as to have an additional parameter in where you have facilities of ultrasound as well as the X-ray. Now we can also go over with the exploratory laparotomy and then see the diaphragmatic hernia. This is the area where there is a hernia. Now coming on to the next important thing is left-sided displacement of abomasum. Although you don't get a severe distension of abdomen, but it is in the peripartum period and there is a scanty duct, and the more important is reduced milking. Other clinical signs important is the ping on left side and scanty feces. The ping on left side is more predominant on the last intercostal space and the paralumbar fossa. So this is the animal. You do the simultaneous percussion and auscultation. So the percussion is done by a flick of the finger and simultaneously do it. And if the outline or what you call a slute, where you get the ping sound, it will be oval and the long axis will be oriented from the left paralumbar fossa, okay, towards the elbow. So you won't get this outline will be like this oval. In case of Reuben collapse, it will be parallel like this, parallel to the vertebral column. So you do the ping sound, elicit this ping sound in case of LDA, and in Reuben collapse, it will be a pung sound. Reuben collapse, the outline will be parallel to the vertebral column. Here, long axis will be oriented to left elbow to left paralumbar. That is an important clue. And then having delineated the outline by means of percussion and auscultation, you put the lip tack test. Aspirate the content and see for the pH, it is towards your acidic side. If you have an ultrasound, see these are the lamellae. So this is the abomasal folds. You will be able to see the abomasal folds and the fluid content, which is a catchy clue for your displacement of abomasum. Similarly, on the right side, you get distension will be there. And if it is valveless, abdominal distension can also be noticed. Important is the reduced fecal output. You get a ping on right side and scan feces are the important things. Other clinical signs I am not touching because this is already there in the note, and all these clinical signs, the clinicians or the veterinarians already know it who are there in the practice. I am touching the salient clinical signs which helps us to hit the acute abdomen. Now, serum biochemistry, important is metabolic alkalosis, and then you can see this is a beautiful ultrasonography picture, just like what you have seen on the left side. So here you are getting on the right side. This is the abomasal folds, and this is the fluid. So important catchy clue is the abomasal folds and this one. You don't get the abomasum here on the right side in the paralumbar fossa or in the intercostal spaces because those are the area of the liver or the intestine. So otherwise the abomasal area is here the ventral area, ventral abdomen. Now one of the management you can do it by tying the animal and then roll and toggle method. There is a preliminary method which has been known. If it is a mild displacement, then it can be corrected. Not in the case of valveless. So roll and toggle method can be also be done, and we have got some success in some cases. So this is a roll and toggle method. You can do it, and then please do the fluid therapy and other corrections of the electrolyte before doing this method. Then becomes easy. So that is another important acute abdomen case, or what you can call as an emergency cases of abdomen. Then intestinal obstructive diseases. So this is more important where there is a reduced fecal output and there will be a colic. These colic signs may not be available throughout, even when the veterinarian is there. This may be available in its history. So that is why you have to ask the owner whether the colic signs are kicking, lying down or getting up, or there before that. So after some time, the colic signs may not be available. So abdominal distension is another clinical sign. Scan feces. An important point for those in the field as well as academicians is to remember the raspberry jam appearance in case of intussusception. This is what is the raspberry jam appearance. This is the raspberry jam appearance is the appearance of the dung. When you do on a rectal examination, okay, the dung which is smeared onto your gloves is like this. This is the dung. To mimic and to easily remember, I have put the raspberry jam or raspberry chocolate, which is commonly available in many shops. So what you do is, this is a normal. When you do in case of intestinal obstruction, rarely you get a dung. You can get the dung raspberry jam like appearance smeared onto the gloves. So raspberry jam appearance is the diagnostic clue. So this is the raspberry jam. So raspberry jam appearance is this one, right side. Left side is, this is what you get when you are asking the 4th year or 3rd year going for a rectal examination if he is a beginner. Or, okay, examine, this is a too much manipulation of the rectum, and after removing it you will get, this is the frank blood because of the over manipulation by a beginner when he does the rectal examination in an animal. So raspberry jam appearance is the right side. To have a easy comparison, I put like this, or you will get this frank blood in case of colitis or rectal problem. Okay. So raspberry jam appearance is right side. And of course, you will get the electrolyte changes. Please correct these changes. And if you have an ultrasound intussusception, you will get a bull's eye appearance. What is that? That is the alternate hyperechoic and anechoic structure. That we will see it in the next slide. A normal intestine, you will get a sacs like this, okay, uniform, and because mostly you will get in a cross section. Very rarely you will get, or occasionally you will get a longitudinal section because these are continuously moving, and you will be successful in getting in a cross section. So now you can see this is how it moves. Okay, in these cases you can see a blackish area in between the intestine that shows there is a peritonitis. Now this is the structures in case of intussusception. Ultrasonography picture. Now you get an anechoic structure, hyperechoic line, anechoic, hyperechoic. This is the concentric ring, what is called as a bull's eye appearance, or called as a target lesion in case of intussusception. So this is a video of it. Video, if you are able to get with a good bandwidth, I think you'll be able to appreciate this. Otherwise, please appreciate with this still image. Concentric, hyperechoic, and anechoic structures. Now that is for the intussusception. Now the more severe will be the mesenteric valvulus, where the animal immediately goes for a recurrency or you have to attend to it because this goes very serious. Rectal examination, you will see multiple loops of intestine, large or small, and the actual arrangement of the viscera, or which one is the dorsal or ventral will be last. The spatial arrangement of the viscera may be last. So important thing, you have to attend to it, diagnose, and then rapidly attend to it so that the animal is not lost. And the other one in the case of intestinal involvement is cecal dilatation. Cecal dilatation, put on a rectal examination, you see the loose feces. Sometimes there will be a colic, and the tympanic resonance will be seen on the right parallel. And rectal examination, you will be able to see the cecum which comes into your pelvic inlet. So you may not be able to see the other contents. You cannot introduce your hand beyond that. Easy to identify the cecal dilatation. The worst of it, cecal dilatation, will be the cecal valvulus, which will be worst. So, and the clinical signs will also go for a detrimental sign. So I have put the acidosis at the last, so that because you need to understand acidosis, especially the sodium bicarbonate administration. Acidosis is a rapid change or a sudden change in the ration or accidental access to the feed storage area. It consumes more amount of unaccustomed carbohydrate. Maybe if it is a number of animals, then you can see the herd also to be seen. It's a very severe case. The animal can go for an hypothermia, and rumen fluid examination, lower pH, and then acidic odor will be there, more amount of gram-positive bacteria. Metabolic acidosis is the scenario, and the simultaneous auscultation and balance, you'll get fluid splashing sound and distended left side. Management, everyone knows, you just put on a tube or lavage it, remove as much amount as possible, and then when you are able to do it, then later on you can go for cut transplantation and then supplement B1, yeast, and the more important is correction of the fluid and correct the acidosis by sodium bicarbonate. So how to identify this sodium bicarbonate? It is based upon the millimoles. Sodium bicarbonate required is, the millimole of bicarbonate required is equal to body weight into this the base deficit into point. How to identify base deficit? In most of the condition you can identify only by blood gas analyzer. So please use -10 as a common substituent in most of the cases. Then you will get the millimole of bicarbonate required in the field condition. So that is the important thumb rule. Then you can calculate, because it is available as a percentage solution, 5% and 7.5%. Under the field, you can always identify each 1 ml of 7.5% roughly supplements 1 millimole of bicarbonate. And each ml of 5% of sodium bicarbonate will substitute or will supplement 0.5 millimole of sodium bicarbonate. If you remember this thumb rule, then it is easy to calculate in the field condition. Actually, it is 0.89 and 0.6. But for the understanding in the field condition, I am telling each 1 ml of 7.5 will give you 1 millimole. Each 1 ml of 5% will give you 0.5 millimole of sodium bicarbonate. So why we have been discussing so long on the abdominal emergencies is ultimately to land in ileus, because that is the topic of today's webinar. So again, identification of ileus and then how to manage this ileus is the ultimatum for this webinar. What is that the ileus so special? This we are talking about a functional ileus, not the obstructive ileus. So what is the functional ileus? Here the peristalsis is last. And then initiating cause is not well documented, but please understand this is more common than your mechanical cause. And it is very common in pregnant as well as in post-parturian cows. That is why you have to identify this ileus and start treating, because you are not liable to lose the pregnant animal or in the peripardium just because it is not passing. So once you identify what is the ileus, then you will save the animal. So initiating factors or influencing factors, dietary factors, sudden change in the diet or phytophagia or enteritis, or the peritonitis, which may be caused by your reticulitis or a foreign body, or any electrolyte abnormality. So maybe a sodium bicarbonate or any electrolyte abnormalities which is caused by your simple indigestion or acid or alkaline indigestion or by enteritis will be causing the ileus, functional ileus, because it is important factors. Or your hypocalcemia. Hypocalcemia can also cause functional ileus. Any pain also will cause decrease in the motility. That will also cause ileus. So all this contributes for an ileus, for which you need to understand and rule out other abdominal factors. You have to rule out peritonitis, you have to rule out LDA, you have to rule out RDA, you have to rule out DH, and then making all other factors as normal, then you can identify or recognize the ileus. So what is the clinical sign? There is no specific clinical signs of abnormalities except hypointestinal motility or atony. So rectal findings, you will see the dung, but the dung voiding may not be as in case of normal animals, but there will be a dung, but frequency of voiding is lost. So milk yield is reduced and there may be anorexia or inaptitude. So when you have facilities like abdominal ultrasonography, you can see the loops of intestine which are dilated, so more than 3.5 centimeter in diameter, and you can appreciate the reduced motility. Sometimes you see a free fluid. What does that free fluid indicate? Yes, free fluid indicates peritonitis. So now you can see this is the size of intestine, but in case of ileus, see the intestine is fairly distended. On the right side, I have given the small size, but if you want to full proof, you can measure this intestine. It will be about 3.5 or 4. So all these use first correction or management of ileus is fluid. What is important is fluid requirement in liters is equal to percentage of dehydration into body weight. That you have to administer immediately. Calculate the plasma requirement, which is 1/12 of this. Pump into the animal, then you will be able to identify what is the requirement. Then remaining ECF you can give it for a period of 6 months. Now, how to manage the ileus? So once you have ruled out all the things are not there, what are the things? The factors which causes abdominal emergencies is not there. Animal is normal and you don't have obstructive ileus, then management of functional ileus becomes easy. First one is fluid, administer the fluid, correct the acidosis or alkalosis. Next is procaine. You can use neostigmine 0.02 milligram per kg body weight. Always use it as a subcut or use it with fluid. Then metoclopramide 0.1 milligram per kg body weight. So you can also dilute it in a normal saline and then you can administer the fluid. Coming on to the azithromycin. So azithromycin is at 8.8 milligram per kg body weight IV for 3 days. So all these have been used as a prokinetic, but azithromycin, it is available as commonly as azithrol. Okay, don't use the tablet, use the injectable because we are going to give IV. Calculate the dose and don't pump it in a single normal saline or DNS. Maybe you can give it 125 milligram or 250 milligram. It is available as a 500 milligram vial. So you can give it as a 250 milligram per sachet, 125 milligram to 250 milligram per sachet, because it initiates the motility. If all of a sudden, if it is initiated, there will be a cramps or pain. So the animal will be disturbing. So you cannot pump in the fluids. Maybe it will require 10 to 15 liters of fluid. So you will be disturbing animal. So don't pump in the azithromycin or neostigmine or metoclopramide. Give it over a period of time. So divide or split it over in different normal size sachets and give it over a period of time. So they split this calculated dosage and then add it in dextrose normal saline or normal. And then don't forget to give calcium, because the calcium is an important representative for the smooth muscle contraction. So always correct the calcium, and it is more common in the peripartum period. And the more important is don't abort the animal. Don't induct of pregnancy. So induction of calving. So don't do that. The termination of pregnancy, don't do it, because it is one of the common condition. Functional is a common condition in pregnant animal. So if you manage with the fluids and prokinetic drug and laxative diet, or sometimes maybe a maxel, the animal will become normal. For that, you need not lose the calf. So pregnancy paralytic ileus is more common. So please don't go for an induction of pregnancy. So now we have used in one such cases, and then we are able to get a drug. And of these 3 drugs, neostigmine, metoclopramide, azithromycin, so azithromycin is able to produce this successful management within 12 hours. Whereas neostigmine and metoclopramide takes a long time. So the animal which is brought to your clinic, which has not passed that, maybe for 2 days or 3 days, so to your surprise, once you have corrected the fluid, electrolyte deformity, and then started administering the azithromycin, an animal will pass done within 12 hours. So that is the beauty of it. And then, so you continue administering the fluids and azithromycin, and then you will see the animal becomes normal, and which becomes recommend. The animal stands up, and then there is a widening of tongue, goes home by walking or standing. So that is the successful management of the ileus. So what is the success in ileus? You have to rule out all other conditions. That is why we have been seeing all the prerequisite for management of it. Then the most important thing for prevention. Prevention is there should not be an abrupt change, and most important is ample supply of water. Any dairy animal, adequate ad libitum supply of water is important. In most of the condition, the reduced quantity of water is one of the predisposing. Then unaccustomed feed, and whatever feed is available, whatever dry fodder is available, that is being given, especially in the dry period, and that is one of the reasons. Or change in the environment goes for a alkaline indigestion or acid indigestion, and the potential cause is your foreign. If these are prevented, and the ileus can be prevented. Then for you to understand, it can also be caused by septicemia or fever or toxemia. Even your mastitis caused by a coliform can also cause ileus. Not immediately, after your mastitis can cause. That would. So you should understand any septicemia or fever or pain will cause ileus. So that is why it is also equally important to understand not only ruling out thoracic or the abdominal part is important. So you should understand, please focus on the thoracic cavity. So for which pericardiocentesis is an important criteria, which you can do it in field. The fourth or fifth intercostal space, keep the limb, maybe on left side or right side, whatever side you are doing it, keep that particular limb in a forward stance, and then put a needle on the fourth or fifth intercostal space, and you will get the fluid. Normally, you don't get a fluid. An animal which has got this type of things, positive venous stasis test or jugular engorgement, brisket edema, jowl edema, you can go for it and you can collect the fluid. So, or you can go for a chest drainage. So you can, this is a chest drainage tube where you get purulent material, and this is, we can see a serous sanguineous material. So normally you don't get this one. Here you get in liters. Okay, we are maybe a purulent, serous sanguineous, or maybe a serous. So that the color of the fluid will tell you what is the stage of the disease. Maybe if the animal is near term, maybe 10 or 15 days are there, then we are using this drainage tube. Okay, we fix the catheter and then we keep on continuously draining the fluid and flush it every day, morning and evening, and then take care with the antibiotic and metronidazole lavage. So this is to save the dam so that the calf has a fruitful delivery. So this is what we are using is in those cases which is near term, 10 or 15 days, not in 6 months or 7 months. So you try to understand the pericardiocentesis site, and if it is a valuable animal in the near term, you can go for a placement of the chest drainage tube, or a newer version of catheter is available. Please identify through ultrasound. This is a normal echocardiography. This is the left ventricle and this is the right ventricle. Beautiful movement of the left and right. Now this is your cardiac. This is your left ventricle. This is the right ventricle, and you can see from here to here is your pericardium with a pericardial fluid accumulation. So you should understand the thoracic cavity involvement to identify your disease. So this is the heart normal movement. I have put for you as a comparison to identify the traumatic pericarditis. So that way I have finished this ileus. So over on to Dr. Santosh or Karnataka sir.
Thank you very much, sir. We will have the question and answer session. I will request Dr. Amit and Dr. Naresh to take the question and answer session.
Yes, sir. Yes.
Okay. Hello, sir. Sir, there are so many questions from the participant side, but I will ask I'll entertain some very common questions on the forum, and then rest remaining questions we can mail you. One question is very common, sir, that has been asked. What will be the dose of azithromycin through
Yes.
IV route during the administration of ileus? This was the question asked by Dr. Sarangdar, and two more doctors, they have chatted about this question.
Yeah, that is a nice question. So please use it at the dosage of 8.8 milligram per kg body weight. Use it IV, diluted in saline or normal saline or dextrose normal saline. Don't use entire dose in a single sachet because it will cause cramps and the animal will have a pain. So use it in a divided dose in many sachets. That will be easy to do the things. So please use it at 8.8 milligram per kg body weight. If you refer to the text, so it may be 1.1 milligram per kg body weight. That is a prokinetic dose. Don't use that dosage. Please don't use that dosage. You have to take care of the One Health concept. Please don't refer into the Google and use it at 1.1 milligram per kg body weight. Please use it at 8.8 milligram per kg body weight, because this is one of the important drugs which is exclusively used for respiratory tract infection in human. So once you start telling this secret to any of the non-vets, please have this within veterinarian. All the veterinarian has to maintain this secret for the mere thing of One Health concept. One Health concept. So to avoid the drug resistance. So please use it at 8.8 milligram per kg body weight for 3 days to avoid development of resistance, because this is an important drug for management of respiratory tract disease in human. Thank you. Next question, sir.
Yeah. Sir, next question is, sir, can we use furosemide for management of TP?
Yeah, you can management of traumatic pericarditis. Can you use furosemide? That was the question. Yeah, very well, doctor. Very well. You can use furosemide. You can use furosemide if you have lanoxin, what you call digoxin, as an injectable form. You can use it. Don't use intramuscular because it causes necrosis. Use it as IV. You can use it. But all together, please identify whether the foreign body is there or not. If it is liquefied and it is not there, you can use it. If the foreign body is still there, if you are going to use cardiac support by lanoxin, the prognosis is bad, isn't it? It will further aggravate the condition. If it is not there, then the other routine is usage of furosemide and antibiotic and restrictive movement of the animals. So that is facilitating the adhesion formation. You can use furosemide.
Okay, sir. Sir, one more question is there. Can we give azithromycin tablet instead of injection?
Now its efficacy in case of calves is good, but in case of the cattle, that's why I told you, please use IV. Please use some more detailed work is going on, and after that work is completed, it will be published. Maybe in next seminar we will be able to tell you what it is. For the time being, use it IV.
Okay, sir. So one question is from Dr. Pranya Kumar Das. Where to do cranial abdominescentesis in diffuse peritonitis?
Yeah. So this I have told. Okay. So where to use cranial? The cranial abdominocentesis site only I have told you. You can take, if you don't have a 10 centimeter from xiphoid, you can roughly use, if you are an adult, a big person, you can use about 8 fingers from the xiphoid. Okay, that will be behind. Then 8 fingers from the linea alba. So then that you can use it. Okay, so that is the rough idea. Otherwise, you can use 10 centimeters like that. That is the cranial side. Caudal side is on the right side in front of the udder. Is it clear? Yes.
Okay, sir. Then we have a question. Sir, can we diagnose this ileus by rectal palpation? this question has been asked, but this is asked from two doctors, but the name is not mentioned, sir.
No problem, no problem. Can you identify ileus by rectal examination, doctor? That's why I told you identification of functional ileus is very difficult because everything looks normal, but animal does not pass dung. Animal does not, the milk yield and the feeding habit is reduced. That's why the scenario for this is look into all this, rule out everyone, then hit at the functional ileus. Probably the doctor would have asked about mechanical ileus. If it is a mechanical ileus, then you may have a chance that distended intestinal loops may be palpable, or you are lucky enough that intersusceptor mass can also be seen through your rectal examination.
Thank you, sir. Thank you very much. Sir, one more question is there. Can we fix displaced abomasum externally by using non-absorbable suture material?
Yeah, that is one of the technique they are using it. You can use it. So abdominopexy that can be done. Okay, either through laparotomy or through that is a routine method. You can fix. But first, before that, you can attempt for your correction of the fluid and electrolyte, and then you can go with this azithromycin also, and then you can go for fixation of the abomasum. That is one of the method. After the displacement of abomasum is corrected, so abomasopexy is important to prevent recurrence. So they do it by abomasopexy. This is a analogy of your gastropexy in GDV in case of dogs.
Thank you, sir. So
Yeah.
one more question is there. It is this question is asked in context to DH. What is the role of keeping a left hand while auscultation of reticular sound in diaphragmatic hernia, DH? This is asked by Dr. Abhinav Sudhar.
Yeah. So what happens is that is a good question. So this is actually you are going to auscultate on the right side. You can do it on the left side also, but herniation occurs commonly on right side. That's why I asked you to auscultate on right side, looking for the peristaltic sound. So why you have to keep it on the left paralumbar fossa is to correlate. So you will hear the peristaltic sound just before your reticular movement, that is pushing of paralumbar fossa onto your hand. So to have a correlation, isn't it? Usually reticular motility, then your paralumbar fossa, that is how it occurs. So to correlate, that's why I put a Williams method of auscultation. So in continuation of that, this has been put, you'll be able to hear the sound, what is called as mixing sound or gurgling sound or peristaltic sound on the diaphragm, which you are fixed on the cardiac area before your hand is pushed by your left paralumbar fossa. That is the idea. Hope you got it.
Yeah, thank you, sir. Thank you very much, sir. One last question, sir. Actually, many questions are there, but this is very common. By Dr. Ashu Arora and two more doctors, they have asked, what should be the size of orogastric tube? I think that was that you explained in the beginning only. So that time only they asked, what should be the size of orogastric tube?
The orogastric tube is simple routine gastric tube can be used. You can see that Yusuf as an adult tube, maybe not more than 1 inch hose pipe can be used. But regularly we have got a metallic hose tube, isn't it? That tube, what is used for rumen fluid extraction, that can be used. Otherwise, if you are going to go for a hose pipe, 1 inch hose pipe, what you use for a garden, okay, that which has got a with supported by wrinkles, those things you can use it, but the problem is the animal chews it. So where you have to use a gag. So maybe you can use that stomach tube for drenching of the fluid, oral fluid, or maybe a liquid paraffin, or maybe vinegar. Always use the stomach tube.
Thank you, sir. Thank you very much, sir. Sir, one question.
One question, sir. A cow weighing 400 kg body weight require almost 3,500 mg of azithromycin. Yes. And how many bottle of DNS or DNS is required to dilute?
No, you can just identify. I told you, you can go with the 250 milligram per sachet. 250 milligram sachet means the cow will roughly require, I told you, 10 to 15 liters of fluid. You have told 450 kg, sir?
400 kg, sir. 400 kg.
400 kg. So 400 kg, you can identify the dehydration if it has 10. 400 into 10 into 0.3. You can see how much fluid it comes. Roughly, it comes to 15 to 20 liters. So naturally, you can use it.
Okay. This question was from Ajit Kumar Sharma. So I hope he
dosage
got
of fluid is, yeah. There are some questions in the chat section, sir. I will go through the chat and then tell how much fluids to be used in ileus. So again, that is why I put that formula, sir. Whether it is a ileus or it is just like any other dehydration, go by the formula. Percentage dehydration into this one body weight. So you will get that fluids. So your aim is to replace ECF. ECF is 1/3 of the last. Immediate requirement is 1/12. That is your plasma. So calculate the total deficit and then divide by 12. That you can pump it immediately within half an hour. The remaining thing, that is ECF, you can give it over a period of 6 hours. But this can be achieved by rapid intravenous infusion set with the 14 gauge needle, which facilitates administration of 500 ml bottle in 1 minute 20 seconds. So that we have got, if anyone is interested, they can contact. We have got it in our university, which is just 450 rupees. Rapid intravenous infusion set, and then you can use a 14 gauge needle. 500 ml sachet can be administered in 1 minute 20 seconds. Normally you will take 5 minutes, isn't it? So what is requirement of 15 liters can be administered in 45 minutes. How to calculate the percentage of dehydration? That is a very good question, doctor. Percentage of dehydration can be calculated by the table. That's, I have not put the table because it is already available in any of the books. So left side will be the percentage of dehydration. Right side they have given the clinical signs. See the clinical sign available on the animal. CRT, skin tint test, sunken eyeballs. By seeing that, left side will give the percentage of dehydration. That dehydration substitute in the formula, you can calculate the fluid. Survivability chance. What?
Yeah. Thank you, sir. Thank you very much, sir. Sir,
Yeah.
One question is very common. Some doctors, they are asking whether this azithromycin is market or not. So for them, just I want to tell ki alembic azithromycin is available in 500 milligram vial. So
Yes.
for them, that I just wanted to tell. Yeah.
Yeah, it is available as azithrol. Azithrol, that's what we are using. You can use that 500 milligram vial. You can use it.
Yes, sir. Thank you, sir. Thank you very much, sir. So many questions are there. The session will be over to Karnandi, sir.
1 minute.
Yeah.
See, sir, all the participants, this azithrol injection is available in 500 mg vial. It is not a veterinary product. It is a pharma product. As of now, it is a pharma product. We do not have the product in veterinary. As Dr. Vijayakumar was repeatedly explaining that it is as One Health policy. Please use it judiciously only for those cases. You do not recommend to any other para-veterinarians. Such cases you yourself treat. That is our request. That is what Dr. Vijayakumar also has recommended.
Yes, sir. Yes, sir.
Thank you. Over to Dr. Santosh.
Yes, sir. Thank you very much, sir. On behalf of all the participants and Alembic Pharmaceutical Limited, myself, Dr. Santosh Shinde, express my sincere gratitude to Dr. Vijayakumar, sir, for such an informative presentation, sir. Rather, I will say, sir, such a practical presentation. You can say applied presentation for the diagnosis and management of acute abdomen and ileus in cattle. Sir, your presentation will definitely going to help the field veterinarian as well as faculty member which are present for the participating the webinar, especially sir diagnosis of ileus and successful management of it, sir. In future also, we will be taking such a benefit of such an interesting and useful session, sir, that will upgrade our knowledge so we can serve the society. Last but not least, I will thank all the participating veterinarian, Alembic field staff for making this webinar successful. Once again, thank you to Dr. Vijayakumar, sir, and all the veterinarian. Thank you very much, sir.
Thank you. Jai Hind.